and welcome to the latest BJA broadcast. And today we're going to discuss a paper in the January 2022 issue of the BJA. And that paper is actually highlighted in the cover that you can see on your screen. The panel on the left showing the test tube of troponin and the troponin molecule on the cover of the BJA. And the paper that we are discussing today is from Sweden, identification of myocardial injury using perioperative troponin surveillance in major non-cardiac surgery and net benefit over the revised cardiac risk index. And you can see on the screen, there's a QR code which will take you directly to the free online full copy of the paper and also some other means of accessing the paper. So I'm delighted to welcome three authors of the paper, and I'm going to ask them to introduce themselves. Firstly, Michelle, if you'd like to go first.
Well, thank you very much for having us, Professor Hopkins. My name is Michelle Chu. I'm Professor of Anesthesiology, Intensive Care and Acute Medicine at Linköping University in Sweden.
Henrik?
Yeah, my name is Henrik Andersson, and I work as a Principal Research Engineer at the Anaesthesia and Intensive Care Unit at the Linköping University Hospital in Sweden.
Good morning. My name is Rupert Pearse. I'm Professor of Intensive Care Medicine at Queen Mary University of London in the UK.
Well, thanks all of you, and you're very welcome. So perhaps, Michelle, I could start off by asking you, what was the main clinical problem that you wanted to address with your study?
Well, Phil, ever since the publication of the vision studies in 2014 to 2017, there have been an increasing number of studies attesting to the value of cardiac biomarker measurements for the prognosis of poor perioperative outcomes. Yet there has been very much uncertainty remaining about how cardiac biomarkers, and in particular high sensitivity troponin T, because there's very little data on troponin I, how that should be used in perioperative care. Is HSTNT a diagnostic test, or are elevated levels simply an independent prognostic predictor of not just mortality, as was shown in the vision studies, but also other poor cardiovascular outcomes? And if so, what levels may be injurious, and when should measurements be carried out? So there is a considerable lack of consensus as well as lack of clarity regarding how myocardial injury that occurs during the perioperative period should be defined. And that was recently highlighted in the STEP Compact Cardiovascular Outcomes Initiative that was published recently in the journal.
Okay, so do you want to just expand a little bit on those differences of view about the nature of the injury?
Yes, absolutely. So the vision studies defined myocardial injury during perioperative care as myocardial injury after non-cardiac surgery. So the emphasis was on a post-operative elevation in troponins, HSTNT in this case. And their definition was an absolute change of 5 nanograms per liter or more when the postoperative troponin level was between 20 and 65, or any absolute value over 65. Now, that's obviously quite difficult to implement clinically. It also doesn't answer the question of whether the change has occurred acutely, whether this is a chronic change, or whether this has happened during intraoperative care or postoperative care. That differs a little bit from other definitions of myocardial injury. So the 4th universal definition of myocardial injury, in that document, any troponin HSTNT elevation over 14 nanograms per liter would be classified as myocardial injury. However, an acute injury requires a change. Now, the Basel group, the Basel PMI study, defined perioperative myocardial injury, so not MINS, but perioperative myocardial injury as an acute change when the postoperative levels were compared to the preoperative levels of more than 14 nanograms per liter. So there is a wide variation in definitions used, not just in the vision and the basal studies, but all other studies that have been published, as well as the timing of measurements.
So as well as being a prognostic marker, is there any evidence to support that an acute therapeutic intervention might be possible if troponins are measured in the perioperative period?
Oh, that's an excellent question, Phil, and this is one of the major bottlenecks for implementation of troponin screening in perioperative care, because the argument is there's not much you can do about it, so why measure it? So there's one trial that has been published, and that comes from PJ Devereux's group. That was a managed trial that trialed the bigatron, 110 milligrams twice daily in patients that have had MINS. And in that trial, they randomized patients to control group care and the bigatron, and there was a clinically significant as well as a statistically significant decrease in the main outcome measure. However, about 50% of those patients did not complete the whole course of therapy, and not all of those patients were able to did not have manifest coronary artery thrombosis. So the results of the managed trial have not really been implemented in clinical care.
Okay, so if I bring you back to your study then, so what was the main gap in knowledge that you were wanting to address with your trial?
Okay, there were several gaps in knowledge. To be honest, we were just confused. We were not sure whether or not troponins, elevated troponins should be used as a diagnostic test, in which case, what would it be diagnosing? Would it be MINS, myocardial injury after cardiac surgery, or should it be perioperative myocardial infarction, or perioperative myocardial injury, or acute perioperative myocardial injury? So these are all different definitions, all using cardiac troponins to define it. So we were also uncertain about the value of HSTNT over and above the revised cardiac risk index for risk stratification. We did not know if HSTNT was independently predictive of mortality and major adverse cardiovascular events, so MACE, after taking into account important perioperative risk factors. So remember that the VISION study and the basal PMI studies were cardiology driven, and they did not take into account the factors that we anesthesiologists consider as important for clinical outcome. So for example, VISION did not take into account ASA class, the RCRI. It did not take into account intraoperative hypotension, intraoperative blood loss, preoperative anemia. Those are some of the factors that we consider as important as anaesthetists. And similarly, the basal PMI study, while adjusting for the RCRI, did not correct for other known risk factors that we as anaesthetists feel are important.
Okay, that's really, really helpful. Thank you. So obviously you're dealing with relatively uncommon, hopefully uncommon outcomes, and you adopted a multi-center approach to your study. What were the main issues you faced in planning it?
Right, so the VISION and basal PMI studies were really well conducted studies. They were excellent, and they were methodologically tip top. However, the cutoffs that they chose were based on predefined hypotheses or predefined cutoffs. Yet despite the different definitions of elevated troponins, all were found to be prognostically important. So we had no idea which cutoffs were important for us to test. So it was important for us so while VISION emphasized post-operative elevations, basal PMI emphasized perioperative increases, we were left wondering what cutoffs should be applied and when blood sampling should be done. So our study was designed around that question. One of the other most important issues that we found was generalizability. It was really important for us to include both large and small hospitals, academic and non-academic units, and a geographically heterogeneous sample size. it was also really important for us to create a pragmatic CRF that included all the vital information that we needed to conduct a robust analysis, but without overdoing data collection, if you understand what I mean. Mm-hmm. And we actually learned a lot from participating in multi-center studies from Professor Pearse's group at the Queen Mary University of London. We participated in USOS, ISOS and PRISM, and we built on this experience, and we used actually large parts of his CRF to inform our own study. So we had to choose the variables for our analysis very carefully. The other major issue was, since this was an observational study, we wanted to be as non-intrusive as possible. Our study nurses and research staff did not participate in patient care, and they collected all the data. All the biomarker analyses were done in batch by the same laboratory, so all blood samples were sent to us, and none of that staff had knowledge of the clinical data or the ECGs, and the ECGs were also collected by staff who had no idea about any of the other outcomes or the biomarker analysis. So the clinicians were not able to access the results of our ECG interpretations nor the biomarker analyses, but they were of course free to do these tests as part of their own clinical pathways. And finally, we wanted to choose outcomes that were clinically relevant, but that were also easy to collect from patient notes and from registries. And we focus on getting complete data sets rather than a very large sample size with a lot of missing data. So there were a lot of logistical issues that required planning with the centralization of laboratory tests and sample storage and ECG interpretation. And of course, the last major hurdle was the cost of the biomarker analysis and storage in the deep freezer. We had to find a deep freezer that was big enough to hold our 8,000 samples. And each troponin test costs about 20 euros, and there were probably about, Henrik will know this better, I think there were about 8,000 samples for analyses. And we had that challenge of finding long-term freezer space for our samples. I don't know how it is in the UK, but it's always a challenge to find -80 freezer space in Sweden. And the cooperation we received from our regional biobank center in southeastern Sweden was just exemplary.
Mm-hmm. Interesting. You find have difficulties keeping things cold in Sweden. One would never imagine it. But okay, that's great, and I'd really like to highlight there one aspect that you didn't try to completely reinvent the wheel, so that you used the experience of others, which people I think often forget when they're trying to design their own study. And again, you've I think been quite pragmatic in trying to get the balance between all the data that you might want to collect and having a protocol that people are going to be able to and are going to be keen to be able to implement. So a great achievement. So over 1,200 analyzable individuals, I think. So that's fantastic. Now, I hate to admit this, but I'm a bit of a statistical geek. I love the statistical side of research. And this is one of the reasons I really enjoyed your paper, because I think you've produced an exemplary approach to the difficulties and challenges of using predictive markers or predictive clinical features. And very often we just see hosts of receiver operating characteristic curves, and it's very difficult to make any sense of them and whether one predictor improves a model or not. So Henrik, for those who perhaps haven't looked at the statistics yet of your paper, what would you say are the key features of your analysis?
Well, our goal was to see how the troponin measurements could increase or improve the identification of patients at risk, and we were putting quite a lot of thought into what method to use for this, because they have strengths and weaknesses there. So Of course, we consider the MRI, which was quite widely used, the net reclassification index. The problem we see with this method is that it doesn't take prevalence into account. So in our case, we had almost 10% of the patients who had outcome, and using the MRI, then with 90% being patients with non-events, the actual index will be explained to 90% by patients with non-events, which is not optimal. So we then looked into the sort of evolution of the MRI called an ARI, which is a net absolute reclassification index, where they do compensate for prevalence. But both MRI and ARI don't allow you to put a different weight to a true positive and a false positive. So I think in most cases, you would value much higher to identify a patient with a life-threatening disease rather higher than misclassifying a patient that will not get the disease. So therefore, we turn to this weighted comparison net benefit method, which allows you to put a different weight on a true positive and a false positive. So
okay, well, sorry, that's absolutely fantastic so far. Is there anything else you'd like to add?
Well, yeah, we wanted to take it one step further, because in the previous publications with the weighted comparison method, then the authors have chosen a weight, saying that, for example, we weight a false positive or false true positive 10 times higher than a false positive. But we wanted the readers to be able to compare the methods with their own opinion about how many false positives you can accept for each extra true positive. So we took it one step further by creating these graphs that we have in Figure 2 in the manuscript, where we plot the weighted comparison index against the range of these ratios, so the reader can make their own judgment or comparison of the methods at the rate that they find acceptable. Mm-hmm.
Brilliant. Okay, so I don't know who wants to talk about your main findings.
Oh, I'd be happy to that. I think in essence, what we found was that elevated HSTNT is a liability, regardless of when you measure it. And when you look at the ROC curves, there is actually very little difference between all the different thresholds that we used. And we found that all definitions of elevated HSTNT were independently predictive of the primary outcome, which was 30-day all-cause mortality and major adverse cardiovascular events. However, we did find that the basal PMI definition, and that is a perioperative change between the postoperative compared to the preoperative value of at least 40 nanograms per liter, provided the best model fit and provided with the largest range of net benefit. So that is to say, it gave the best trade-off between true and false positives. Now, I believe that there are dual benefits for the measurement of troponins, given the results of this study. So firstly, preoperatively, to aid in risk assessment and risk stratification. So that is one finding. And postoperatively as a prognostic marker, as well as to detect and otherwise miss complication at an earlier stage. So the value of troponin surveillance is not dichotomous. It's not a yes and no answer. Like all biomarkers, as Henrik says, it depends on the prevalence of the disease, the consequences of disease, and what therapy there may be available to treat that disease, and what degree of risk that patients and clinicians are willing to accept.
I thought it was really interesting that you had a reasonable proportion of your troponin increases in the immediate postoperative period.
Yes, that's correct. In fact, most of the increases occurred very early on, and that would be consistent with the myocardial injury occurring during the intraoperative period or immediately after. So most of our patients suffered from myocardial injury between the postoperative, the intraoperative period and day 2.
Mm-hmm. And so that's does suggest that we do have scope for appropriate interventions, because classically patients who develop a post-op myocardial infarction could have that develop that several days post-operatively. So we've got the potential of a marker and that gives a window of therapeutic intervention.
Indeed.
One of the things, you've got a huge amount of data that you presented in your paper, and again, thank you for that. And one of the things that I picked out was that some of the variables that one might have expected to be predictive of the poor outcome weren't predictive at all.
Yes, we were surprised too, and I suspect that you're thinking of intraoperative hypotension.
Mm.
That was not predictive of the primary outcome. It was not predictive in any of the sensitivity analyses, and we thought we made a mistake. So we went through all our data files again, rechecked all the data, analyzed the data, blood pressure data in different ways. You know, we used different absolute thresholds, we used different relative thresholds, and none of the analyses were anywhere near significant. So that was certainly a surprise.
Mm. And so how do you balance that with, there's been quite a lot of recent work about intraoperative blood pressure changes, heart rate changes, and outcome?
That's a good question, Phil, and I was afraid you'd ask me that. I wouldn't say that, well, this study was not a study designed to investigate the effect of intraoperative hypotension on clinical outcomes. That was one of the covariates that we thought was important to include in the analysis, because this was, this was not done in the other major studies that we had read. We fully expected intraoperative hypotension to be strongly predictive, given all the other large and well-conducted, well-adjusted observational studies that have been published. So this came as a total surprise, and perhaps in that constellation of variables, I'm convinced that intraoperative hypotension is important, and this study does not show that it is unimportant. But perhaps in that constellation of variables, its relative meaning is probably less than say in other studies where different confounders have been adjusted for.
I don't know whether, Rupert, you want to add anything on that point.
Yeah, so I mean, it's a really interesting question, because one thing that Michelle's done so nicely in this study is collect so much robust covariate data that allow you to have a very sophisticated multivariable model. And of course, if you get the right variables in your model, there can be things that we biologically know are causally important that mathematically seem unimportant in the model. So if you've got really robust troponin data, for example, that represents the harm that hypotension is signaling. In that context, if those data in your model, then hypotension mathematically can appear unimportant. And so I think that we need to sort of, it just speaks to our understanding of the biology of myocardial injury, of what is actually happening here. And if you select a group of patients and you phenotype them really carefully in terms of preoperative data, as well as preoperative troponin. Now, I think hardly any of the previous studies of hypotension and tachycardia, including the ones from my group, have had such detailed covariate data. So I suspect that this isn't saying that hypotension isn't important, just as Michelle says. It's got more to do with a more profound understanding of the biology that Michelle's shed the light on in this paper.
Coming back to your study, Michelle, if you were to do it again, I don't know whether you've got the energy to do something like this again. It's a bit like Rafa Nadal coming back from 2 sets down, isn't it? but you know, how would you do things differently, or would you do anything differently if you had to do it again?
I guess we would reduce the frequency of blood sampling. We had 5 sampling points, and that was difficult for our study nurses, and I think admittedly it was difficult for some patients. You know, having somebody knock on your door immediately post-operatively and every single day after surgery was I thought was quite invasive in many ways. Patients don't feel their best after surgery, and if we can reduce the frequency of sampling, I think we should do that. And this study shows that we could probably get away with a 3 sample surveillance.
So when would those samples be? What
preoperatively? Yeah, preoperatively day 1 and day 2.
Mm-hmm. Yeah, I think that would be a really big help for other people who are wanting to do studies in this area. Brilliant.
Yes.
Anything else?
Hopefully that will, you know, help researchers go further with the timing of measurements. And we'd also like to collect more granular data. I know we talked about, you know, having a CRF that was reasonable and not wanting to collect too much, and having a complete data sets. But we have very little data on type 1 and 2 myocardial infarction, in particular type 2 myocardial infarction, that overlaps considerably with a perioperative myocardial injury, because it would be nice to understand the possible causes of injury and to differentiate acute perioperative myocardial injury from type 2 myocardial infarction, because they are likely to have different treatment pathways.
Mm-hmm. Okay, so I think that brings us on to how you think this particular study has impacted our scientific understanding and how it might impact clinical practice.
So in my view, this is one of those areas of practice where we need a growing diversity of evidence from different countries, from different research groups, looking at the problem in a different way to build up a granularity of understanding in the research evidence base. We now know, and we've known for a while because of the VISION study, there's this tremendously important topic. But different researchers are taking different methodological approaches, they're using different definitions of the pathology that they're looking for. And it's shaping the results in particular ways, and different data sets, different covariates, and so on. The use of a preoperative sample in Michelle's study, which wasn't a feature of some of the other important studies, most importantly VISION, which is the biggest to date. So all of that, those research methodological approaches are shaping our understanding of this biological problem. And I think, for me, really, what we have to get our head around is just the complexity of this, what is almost certainly a syndrome of diseases. It's not one single thing. It's not just plaque rupture, coronary thrombosis. Now, that's obviously going to be an important part of the problem, but it's not the only part of the problem. And I think it's really important that we get over that now and we move past it and we start to see this as a multifactorial syndrome. I think that's one thing. The other thing is that those of us who are old enough to remember the introduction of troponins, and not just the 5th generation high sensitivity versions, but the older versions, it transformed our understanding of what was happening to the heart, because this assay is so sensitive. And in fact, it's so sensitive that rather than accepting that any troponin in the blood is pretty much abnormal and indicative of myocardial injury, we had to find reasons why troponin in the blood was abnormal and could be ignored. So if you look at end-stage renal failure, for example, for a long time, we told ourselves that troponins in the bloodstream of patients with end-stage renal failure didn't matter, until somebody did a large epidemiological study that showed that if you did have troponin in the bloodstream with end-stage renal failure, you're more likely to die. And this really, it's our ability as human beings to understand the biology here. And because we can't understand it, we're trying to simplify it and go, no, it's far simpler than this. It's just this problem, or it's just that problem. Or we're fitting a binary definition to something that really should be measured on a continuous scale. Now, for example, research funders don't want to fund studies of biochemical measures of outcome. They want patient-centered outcomes. So we take our biological measure, we turn it into a binary variable and say it's a patient-centered outcome. Now that's a great success for making it appear patient-centered, but it's a huge failure in terms of research methodology, because we take away that complexity. Now, if you look in intensive care, we see myocardial injury after trauma, we see it after subarachnoid hemorrhage, we see it in sepsis and so on, and it's often quite significant. And it seems obvious to me that patients who are having major surgery may have a similar pattern, because a lot of them experience that systemic inflammatory response. It also makes sense that the pattern they see is less severe than a critically ill patient, because the trigger of that systemic inflammation is less severe. So we're seeing a phenotype of myocardial injury that looks quite like that syndrome of myocardial injury we see in ICU, but for most patients it's less severe. Now that is absolutely no surprise, because you get the same picture with acute kidney injury, which we see a lot in critical care. We also see it after surgery, but on the whole it's less severe. The same thing with delirium, the same thing with lung injury, and so on. So we're seeing a pattern across all organ systems of tissue inflammation related organ injury, and it just is defined by our ability to measure it. And in the case of the heart, we have this tremendously sensitive and reliable biomarker in high sensitivity troponin I and troponin T's, and that's giving us information that we're perhaps not quite ready to come to terms with yet.
So not quite ready for translation into clinical practice?
Well, no, I wouldn't go as far as to say that, because first of all, anything that tells us what our patients' short and long-term outcomes are offers value in terms of aftercare. I think that we have been unable to identify acute interventions for this pattern of myocardial injury, but it may be that we're looking in the wrong place. I would be really interested to follow these patients up for the year after surgery and see what the incidence of heart failure is, for example. And my guess is, and there's no evidence to show this, but my guess is that patients with myocardial injury have an increased incidence of heart failure. And perhaps if we're following them up maybe at 3 months after surgery and offering a proper heart failure assessment, and maybe starting ACE inhibitors or other heart failure preventive drugs, that may be the opportunity to improve their outcome. And if we look at myocardial infarction, for example, some of the treatments that have had the biggest impact on outcomes after myocardial infarction have been drugs to prevent heart failure after the event. So, you know, we need to be thoughtful in where we're looking for opportunities. And we shouldn't underestimate the importance of prognostic information that tells us what patients' likely long-term outcomes will be.
Mm. Do you think we'll be able to persuade our clinical biochemistry colleagues to do the assay?
Well, that's just a question of financing, isn't it? In a lot of hospitals, the budget for biochemistry is held within the biochemistry department, and so you have to actually create quite a strong business case if there's a need for that data in another department's budget, and those kinds of issues can be real obstacles to improving patient care at times. But I think that as our use of these assays becomes more common, we'll find that the costs go down and it's more normalized that we measure them on a routine basis. Now, we don't need to measure them in ambulatory surgery as a routine basis, but I think patients having major abdominal surgery or major vascular surgery, for example, clearly need regular troponin measurement. And I think once that becomes a normal thing, we'll start to transform our approach to how we use those data to care for our patients.
Thank you, Rupert. So I think both Rupert and you, Michelle, have given us a little flavor of further research in this area. Do you actually have anything planned related to this, or you're still recovering?
I think we're still recovering, and Henrik is probably tired and doesn't want to see me for a few months. I think, well, actually, Phil, I think there are two parts to this question based on what we found. The first step is the measurement of preoperative troponin, in addition to the RCRI for preoperative risk stratification. And this is likely to be of greatest benefit in patients at already elevated cardiovascular risk. And there is something that you can do about it, as Rupert suggested, because, you know, perhaps we should be focusing on preoperative optimization of these patients to reduce the incidence of acute perioperative myocardial injury and following that poor cardiovascular outcomes. And this may include, you know, optimization of cardiovascular medications, ACE inhibitors, beta blockers, aspirin, a cardiac workup, correction of preoperative anemia, which still occurs despite this being elective surgery, extended perioperative hemodynamic monitoring well into the postoperative period, meticulous attention to intraoperative hypotension, intraoperative homeostasis, all those sorts of things that we are supposed to do, and we probably don't do that well when you actually measure it. Those are interventions that are still possible to do. So that's preoperative risk stratification, what we can do about it. The second step is the actual measurement of postoperative troponins on day 1 and 2. That's a suggestion after surgery. And the purpose of that step is different. That step is to identify the patients with acute myocardial events at an early stage. And these patients are largely asymptomatic, as the VISION study and the Basel study also showed. Now, patients with acute changes in troponins should be followed closely, obviously, and acute myocardial infarction, both types 1 and 2, should be ruled out, because those are diagnoses that you can do something about. There are also a number of other causes of myocardial injury that have evidence-based clinical treatment pathways, and these would be, you know, heart failure, as Rupert also mentioned, arrhythmias, hypotension, sepsis, pulmonary embolus. So while those diagnoses are not encompassed under MINS, because MINS only deals with myocardial injury post-surgery due to presumed ischemic causes. So our definition encompasses a very much a broader umbrella of diagnoses or syndromes, as Rupert puts it. And many of these have evidence-based treatment pathways. So we perhaps, you know, without having a single drug or a single program to treat perioperative myocardial injury, I think we are able to manage our patients in a better way. And I think that would be a future research priority.
Thank you. I think that's probably a really appropriate place to end our conversation. It's flown by. I've really enjoyed it. Thanks ever so much for joining me today, and congratulations to you and to your co-authors on conducting such a magnificent piece of work that I'm sure is going to inform future studies and ultimately inform our clinical practice. So Michelle, Henrik, and Rupert, thanks very much for joining me, and thanks to those of you who have watched the broadcast. So it's bye-bye for now.
Thank you very much, Phil. Thanks for having us.
Thanks, Phil.